here today at Dr. Akbar Niazi Teaching Hospital, and the subject that we're going to talk about today is surgery, and not just general surgery but pediatric surgery. And for that we are going to talk to Professor Dr. Nadeem Akta, who is a pediatric surgeon, and he's going to give us lots of information concerning children's health, what parents need to look out for, and we're going to ask him to give us a visit of the hospital and the different facilities that are here. So let's go and meet Dr. Nadeem. Okay, now we are sitting down with Professor Dr. Nadeem Akta, who is a pediatric surgeon and also head of department here. Thank you very much for taking out the time to see us today.
Thank you very much for coming all the way and having a talk with us.
It's a pleasure, it's a pleasure. And the most important thing I think today that we're going to talk about is the actual, pediatric surgery, what it entails, what it actually is. And do people really know about the difference between an adult surgeon and a pediatric surgeon?
Yeah, this is a very interesting question that you have started with. Let me start from the outset that pediatric surgery is a different field of surgery, it's a different specialization altogether. Basically, it is a specific age that we have patient related in that particular age group. So if we take right from the time of birth, so by a British count, we take it to about 13 years of age, like up to 12 going on 13. And this is a specific age. And why it is specific and why it is separate from adult surgery, because the set of problems that we see in the pediatric age, they are totally different from what we see in the adulthood. Mm-hmm. These are the children who are born with lots of malformations and diseases which have to be corrected in that particular age. And if not corrected properly, they go on to adulthood with all these problems, and then it's very difficult to treat them. So that is why there was a need early, which was recognized by the turn of the 18th century, that this should be a separate entity altogether, and the surgeons should be totally separate who are well versed with these conditions and with these problems. So with this background information in mind, and with all the research that was carried out that time, and this then became a reality that this is being separated from adult surgery as an independent specialty, which we call as the pediatric surgery. Not only that, within the pediatric surgery, there is further specialization in the age group. Like we have the neonatal surgery. Neonatal surgery encompasses the children who are born from the time of birth up to 1 month of age. So you can see that's just the 30 days interval, but it's a different field within the pediatric surgery as well, because they have a different set of needs and different set of requirements. So it is not just the type of diseases which are different, but their requirements are different. For instance, a child cannot be placed with an adult in the same bed or in the same environment or same setting, Right. They need toys, they need colorful environment, they need cheerful nurses. Exactly.
Yeah.
So all these things put together, this makes a separate specialty altogether.
Right. Now, having said that, the needs for it and everything, how much of that do we have available in Pakistan? Is there a heightened awareness towards this need, and what is being done about it?
Yes, I'll take it a little further back, and actually few surgeons in early 60s, once they were exposed to this specialty in the West while they were being trained, when they came back, they thought that they should replicate the same models here. This is how it started, at an individual level, and this was started in Karachi. And then there were some other centers which mushroomed in few other cities like Lahore and Multan. So it was only limited to very few centers to begin with. But as the awareness and as the need that increased and more surgeons were trained, so it went on to get established in different cities, but by and large it remained primarily focused in urban centers. Okay. So still it did not find its roots because of lack of number of surgeons and the lack of the hospitals which are available with us and the resources in a constrained environment. So it is only present in the urban areas, in the urban cities.
Okay. Having said that as well, we have, talking about customs and traditions here in Pakistan, we have a lot of intermarriages, cousin marriages. Does that contribute to the cases that you see that a pediatric surgeon will have to deal with?
Absolutely. This is one of the important reasons to have, or one of the etiology, what we call it, to have a congenital malformation. And it's an established fact beyond any doubt that many diseases, they come from intermarriages or cousin marriages, which is a big problem here. And there are many diseases like thalassemia, for instance, and which the West has sorted out by identifying the genes and then genetic counseling, what we call it, and the parents are aware that they should not have an intermarriage to prevent these problems. And likewise, there are many other defects like the bone defects and the spinal defects, and children who are born with big-sized heads, and so on and so forth, and many cancers, which has a familial tendency and incidence.
I see.
So absolutely a very important point to understand that this is something which should be discouraged.
Do you get a chance to counsel your patients, and what is the response when you tell them about, because this is something that is widely discussed as well, but not many people really adhere to it. So how do you deal with counseling parents that come in with this problem?
Well, counseling is a very important domain of a pediatric surgeon, and by and large they do respond well, but obviously something which they were not aware of in the past, and obviously once the awareness is given to them, and so they are more cognizant of this, the fact that probably they would inculcate all this information in future for their children. And it is important for parents, if there is one sibling or one child who is born with a congenital malformation, and to be aware that this child, once he goes into reproductive age, can have children with similar malformations, So obviously counseling is a very important backbone of pediatric surgery, and the response is very good. They respond very well. And not only that, we take it a step further. We have now clinical geneticists which are available with us. And when we run these clinics, these genetics experts, they are available, and their genes can be mapped and they can be traced, although it is a little expensive, and these tests are not done, by and large, majority are not done here in Pakistan. But then the families who can afford and who can be helped from some other collateral resources, gene mapping is now a reality where they can find out the exact cause as to what was the predisposing factors which led to those diseases in their children.
Right, okay. Let's talk about more and more people coming into this field, pediatric surgery. Are you happy with the data, if there is any? How many medical students are geared towards this? Is this something they have to be sort of guided towards, or do they learn about it while they're training? What actually goes on?
I think there is an awareness now. The medical students, they are well aware because of, the knowledge is not limited now. They have an access to all the information. So we do get medical students who develop interest in this specialty right from the very early part of the training. Unlike when we were in that process, we were not aware that this exists as a separate specialty. So the awareness is very much there, and then I think it offers a great opportunity for them to establish themselves as pediatric surgeons, because still we feel that the competition is less, and the number of patients that are in this particular age group are very many in number, because you will be surprised to know that the last census that was done in 2018, about 40 to 45% of our population falls in an age group between birth and 18 years of age. So you can imagine the kind of opportunities that the medical students can have later in life once they go on to become pediatric surgeons.
And also to think of that ratio, so many children do not have access then to a pediatric surgeon because of not having enough in the country. So that would also be something that needs to be worked upon. Do you have to have a specific temperament when you're working with children to be a pediatric surgeon?
I take a phrase, and I always tell my student, child is not a small adult. Child has his own intricacies of not only handling. Obviously, we are trained over a period of years to understand and to handle these small, delicate babies right from birth till 12 or 13 years of age. But not only that, we must understand their psyche, And not only the children along with the parents, we have to take them along with us.
That's
so
true.
that they understand their diseases, because the trauma and the pain, of course, has to be, it is not just the child, but the whole family involvement is to the level that they have to be taken along. And a lot of sessions, a lot of time is spent in making them understand and counseling them what is best for the child. And not only that, many of our procedures, they are staged procedures. Like, it's not just a one-time interaction with a surgeon. They have to come time and again for the diseases, and they are done in bits and pieces, or in staged reconstructions are done. There are many diseases. So the family is attached with us for a very long time. Like, one bit we may have done in very early part of their life, and the second surgery may take after 1 year or 2 years. So they may be with us for an extended period, unlike many adult surgeries which are done in just one go. So, yeah.
Which means that relationship is so important.
Not only the relationship, it's the trust which they have to evolve on the surgeon. And I think this is a big virtue to take the parents along with us and make them a part of the treatment plan. And we make use of modern techniques to help us out. We have the handouts which we have prepared for the different diseases, which we give them to the parents in their understanding, at the level of understanding and knowledge that they have in their language, because we have a large catchment area, and parents come from different cross-section of the society and from different areas, speaking different languages. Okay. So we have to take all that into account to make them understand in a better way.
So you have different languages then to cover
Absolutely.
the different...
Absolutely,
Okay,
because we have a catchment.
Important.
Yeah, absolutely, we have catchment area as far as Gilgit and Baltistan and the northern areas as Jammu Kashmir, because capital area is one area which drains a very big catchment area. And not only here, you will be surprised that we get patients from across the border. We get a lot of patients from Afghan population, not only the refugees, but also because of the geopolitical situation. A lot of these patients, they are flown in here as an emergency, or they find their way to us for the definitive treatment and surgeries. And we also get patients from Middle East, from West, even people are the diaspora who are spread all over the world, and when they're visiting Pakistan, they do come to us. So we have to cater their needs and requirements in terms of their understanding and language.
Tell us about the Childhood Cancer Awareness Month and what's happening here.
Yes, this is a very important point that you have struck. Cancer is, we call it the pediatric oncology. So we have services which offer treatment for cancer. These can be solid cancer, solid organ cancers, and blood cancer. And for that we have the bone marrow transplant unit, which is available within our facility. So under one roof we offer them the surgical care, we offer them the medical care. As you understand, the cancer treatment is not only expensive, it is very long, it is very painful, and a lot of cost.
Emotionally draining as well.
Yeah, exactly. It is draining for the parents. So we offer them a comprehensive treatment for cancer patients, for all kinds of cancers. And this is the month of September is designated as an awareness month for these patients. And perhaps you're aware that it is very important to pick up cancer very early, once before it spreads to different organs. Yeah. So awareness is something which is of paramount significance, and the parents should report to the doctors early, where they can be picked up, diagnosed, treated, and then eventually the outcome is quite good.
For example, what things should parents be looking for when we're talking about cancer awareness? What are the things that you see a lot?
This depends upon the type of cancers. Like, if we have cancers which affect the solid organs, like the kidney cancer, for instance, which is one of the common malignant tumors in the childhood. We call it the Wilms tumor. The child would have an excessive loss of weight, there will be excessive crying, he will not be thriving very well, there may be some blood coming in the urine, but by and large, fever, ill health, generalized malaise. So these are some of the common symptoms which most cancers share in common. Okay. And once they visit appropriate centers and specialists, these cancers can be picked up in very early part of once they're just starting to sort of spread in the body, before the spread. And that is the time once either surgically or medically they can be cured.
Right. So to make it easier for the parents to understand, what they would see is that if your child is losing weight, as you said, crying for no apparent reason, they have a fever, then the first thing they should do is visit their pediatrician, who would run some tests, and then they would be referred to wherever, depending on the test findings.
Absolutely, and there are many cancers which require a combined approach of a surgeon and the pediatrician, where we have to operate upon them, we have to remove those organs, and so it's a combination. And we have a tumor boards, which is a more wider concept of going, instead of sending them to different departments, what we do is we have a regular tumor board meeting. These patients are discussed by a panel of specialists who sit with the parents in one place, and they run all the tests and discuss amongst themselves, and they give them a treatment plan and protocols, and if those are adhered to and followed, the cure can be inevitable.
Right. When we talk about cancer and we talk about, adults facing it, when you speak about children and then cancer, it's a completely different scenario. How do you counsel parents then? How do you deal with children? Is there a different sort of a regime when it comes to chemotherapy with children? What is it?
I think breaking a bad news is always a very daunting challenge for us. But breaking a news there are ways of doing that. And we have to of course, sit with them, trying to make them understand what the child have, because the knowledge is absolutely important for them. They should have a thorough understanding so that they can take correct decision for the child. So breaking a news is something which really is a point is reached where it's very difficult for us, but then of course we do it with a lot of skill, and we take the older family members into confidence, and we tell them, and gradually and slowly we need to inform the parents, because eventually the parents must know what is going on with their child.
So that they make an informed decision.
Exactly, because the decision rests with them. We cannot do anything without their total consensus and agreement. And if they're not taking a correct decision for the child, we help them or make them understand. And then we have a lot of those charts, a lot of those clips which we show to them, and we share our data with them. That obviously that helps them in having more confidence in our system and in ourselves as well, that this is not the first time that we are handling such children. So by and large, once we have a group, or as we said, that we have a tumor board, and once that is in place, this becomes a more easier for us to explain them.
With the pandemic and COVID hitting the world, did you see a sort of a surge in pediatric surgeries relating to the virus?
Absolutely. I think it's not the virus itself directly affecting, or it's still, we don't have any data where it is proven that the virus has caused certain increased incidence in pediatric surgical problems. But what went wrong was that because of isolation and most of the hospitals, they were closed.
People were avoiding the hospitals anyway.
So our waiting list that went on to sort of increased in phenomenally high numbers. And this phenomenon was not only experienced in Pakistan, but also in West. Like if you take NHS, their waiting list went on to more than 2 years, you'll be surprised, for common surgeries, because those operations were cancelled. So that has added a lot of burden to the healthcare system, and we are still facing the aftermath of the pandemic.
Yeah, you spoke about Nicu as well, and birth defects. Tell us a bit about those. What are the more common ones? Is it something to do with where you are globally in the world as well? Does that make an impact, make a difference? What do you see in the cases that are presented to you?
I think Nicu is a very important part of a pediatric surgical practice. The children who are born with problems, with severe defects, and these are categorized into two broad categories: those which are like an emergency surgeries, where if you don't do anything within minutes or hours, that could make a lot of difference in life and death. And then there are a set of problems which just needs to be identified, parents need to be told about them, and they can be managed subsequently as the child grows. Now, the emergency problems are very many in number, and they can be life-threatening emergency. For instance, a child who's born without an opening through which the child neither can pass stool or cannot pass urine. And this is an acute surgical emergency. Or a child is born where the intestine is obstructed, or a child is born with airways not functioning to its optimum level. Now, these surgical emergencies, they have to be dealt with immediately after birth, and they require a backup or a support of neonatal intensive care unit. So we in Pakistan, we still lack a lot in this particular area. We do not have the neonatal ICUs or Nicus in appropriate numbers where these children can be handled. And you'll be surprised that we have a very high birth rate, and the figure shows highest in South Asia, and proportionately we do not have these ancillary services in place. So that becomes a limiting factor in operating and in their survival.
And then again, these would be those defects that would have had to be picked up during the pregnancy from, or is it something you find out after the delivery? I mean, there must be some instances when something surprises you, or is this everything that is picked up before?
Well, ideally they should be picked up before surgery, because that is what we call the screening, and the screening ultrasounds are carried out in these children or in an antenatal period, and it is at that time when these patients should be referred to the pediatric surgeon, where they can counsel the mother where the child has to be delivered, what should be the timing of delivery, and what should be the mode of delivery. But since the screening is not available to everyone and only in specific centers, so by and large many children are born who are where these diseases are not picked up before birth. Right. And that becomes a rude shock for the parents as well, that they find out that the child, the mother has gone through all the difficulties in labor, and suddenly they find that the child has a severe or a very problem for which the child needs a surgery, and they rush to a hospital. So that is something which can be avoided if these children are picked up and screened by people who understand these problems and in major centers. So that is why screening is very important.
Right. What about surgeries before birth?
Yeah, this is still in the developmental stage. It is an established fact. We call it the fetal surgery. Now, the fetal surgery is very fascinating, and this is where the future lies, where these should be picked up in before birth, and then these surgeries can be carried out. But even in developed countries, there are few centers only, and that too in the experimental stages.
Oh,
so for us to reach that level, probably it's a long journey.
Right.
So for us, I think if we even pick up these diseases antenatally, as you said, by screening, so probably that is where we should head for.
Let's talk about telling parents about emergencies. Any instance that they should take their child to see a pediatric surgeon straight away?
Well, a child should be seen by a child specialist. Let's be very clear about that, right? Even if it's a medical problem, it should be seen by a pediatrician or somebody who has experience in dealing with children.
Right.
And if they have life-threatening emergencies, these doctors should be able to pick it up. And our medical college now do have the curriculum where these doctors are aware of these conditions, and they are taken through a process of information and knowledge which they have. And what they should do is they should refer these patients immediately to those centers where the pediatric surgical facility is available at hand, and where they can be properly dealt with and operated if needed. Yeah.
Okay, and let's have a final question, a bit of a different one. Children communicate in their own unique language. They don't use words. How do you understand what you need to do?
Yeah, we as a clinician are very observant. A shrewd clinician has to observe, and our observations start right from the time when the patient enters our room. And we saw, for instance, if a child has an appendicitis, let's take it as an example. We have to observe him right from the very beginning, how he's walking. Is he walking with a crouch? Is he in pain? So although we are talking with the parents, but we are also observing as to the grimace or the face of the child, as to what kind of an expression, what kind of an agony, what kind of a posture the child is adopting. So clinical examination and clinical acumen is something which is of paramount importance for a shrewd clinician to arrive at a conclusive diagnosis.
And that's what many parents don't actually realize. They may think that they came and sat with you and they've been talking to you, and then you come to a diagnosis or something, and they're like, you didn't listen to everything I said, and they're not actually understanding. So that is very important.
That's absolutely important. Yeah, observation, and that is the backbone of our examination. Yeah,
right.
We touch later, we examine first, so we observe first. You know,
that's
we look
fascinating.
At the child.
That's really important. Okay, Dr. Nadeem, it's been wonderful talking to you, and we've talked about lots of subjects. Now we'd really like to go and show our viewers the different departments in the hospital and what is being done for children here, the different expertise and skills that are being offered.
We at Dr. Akbar Niazi Teaching Hospital here where we are sitting, this is a clinical hospital. It's a tertiary care center, more than 500 beds, and affiliated to Islamabad Medical and Dental College. Regarding my field, we have a full-fledged department of pediatric surgery. We have a backing of the Department of Pediatrics. It is a professorial department. We have a Nicu, or the Neonatal Intensive Care Unit. Then we have the Pediatric Intensive Care Unit. Then we have the Bone Marrow Transplant Unit here and the Pediatric Oncology Center. We have a full-fledged OPD and an accident and emergency, fully active departments which are running with their own staff, with their own beds, and they are offering these services around the clock to the patients. So we can go and we can see these departments individually if you so desire.
Wonderful, let's go. Okay, Dr. Nadeem, can you tell us where we are right now and about the patient as well?
Well, this is an area which is designated for bone marrow transplant patients. This is called the Bone Marrow Transplant Center at Dr. Akbar Niazi Teaching Hospital. I'll just give you a little bit of background about what bone marrow transplant is. This is basically a therapy for those children who do not have a kind of cancers or those diseases which cannot be treated by medicines alone or surgery alone. So the stem cells are transferred to the bone marrow where they reproduce and they take over the cancerous cells. So the bone marrow transplant centers are not available in very many number across the country. So this project was started here in collaboration with another organization in Italy who's helping us here in the collaboration, and we have a highly trained professionals who know how to carry out these procedures. They need a special areas, a special environment, and they need some surgical long lines which are placed over here. They are immunosuppressed, so they have to be kept isolated from other patients. Okay. So besides the bone marrow transplant, we also have patients like we currently are sitting here with a child who's unfortunately has a kidney tumor, which we are planning to do surgery. It was very big, we could not remove it up front, so we gave chemotherapy. The size has shrunk in size now, and we are planning surgery in the next 2 or 3 days.
Okay, right. And this is his father?
Yes,
how did they come to see you? What were the symptoms that they found?
Yeah, they presented in our outpatient over here with an abdominal mass, or the tummy was protruding out. And in the course of investigation, we found that the child has a very lethal renal cancer and was investigated. And once the investigations came and we discussed it in the tumor board, the upfront surgery could not be offered because the tumor had already spread. It was very big in size.
So it was first controlled by the chemo.
Our very competent team of pediatric oncologists, they have given several cycles of chemotherapy, and now the tumor is smaller in size.
He's responded well.
Yeah, it has responded well, and hopefully we will be able to do the surgery. And as a surgeon, now it is my domain to interfere and intervene and remove this tumor.
Best of luck with that surgery. Hope he gets better very well.
They're happy to be with us.
Right, that's wonderful. And where are they from? Where do they come from?
They come from Gilgit, Baltistan.
Okay, right. Okay. Where are we right now?
This is a place called the Pediatric Intensive Care Unit. We call it the PICU, or the PICU. At Dr. Akbar Niazi Hospital, this is a fully equipped pediatric intensive care unit. It has 8 beds, and as you can see, it has a central monitoring, the central supplies, and there is a fully equipped central monitors where the doctors and the nurses can monitor these patients. So after surgeries, the patients are brought in here, especially the ones who undergo major surgical procedures, and for the duration that is necessary to keep them and observe them.
Right.
Not only that, many of these patients, they require ventilatory support, like we carry out the surgeries where the child cannot breathe to the level that we desire, or to keep him pain-free, we do an elective ventilation. So this is well equipped with those ventilators, and a very trained, highly trained, dedicated staff and nursing staff which is available with these children till they recover and are well enough to be sent to the step down or the wards.
Okay.
From here we can go to the neonatal intensive care unit, which is called the Nicu, and
those are the little babies where they
those are for smaller babies, from birth till
1
month of age, and this is from 1 month till 12 years of age.
Right, so let's head there
Let's
then.
go there.
Right now we are standing outside the Nicu. We're not going inside because the babies here, of course, are very, very vulnerable. Dr. Nadeem, tell us about what's happening here.
Yeah, this is an area called the Neonatal Intensive Care Unit, NSU, or the Nicu. This is one of the most important area where babies who are just delivered, and to be very precise, the age group is from the time of birth till 1 month of age.
Okay.
And both the medical and the surgical patients are kept here in intensive care unit. As you can see, it is very well equipped with a very modern incubators, because these babies, you have to maintain their temperature, you have to give them special fluids. The nursing care is very, very special and unique, specific to them and to the kind of diseases they have. And they have to be kept separate from each other so that there is no cross transmission of infections from one child to the other child. So here in this hospital, we have a fully functional, well-equipped neonatal intensive care unit, and we perform all kinds of surgeries with a lot of confidence that these babies will be managed in the post-operative period in this setup.
Right, and after 1 month, then they go to the PICU, the Pediatric ICU?
Either they are cured or they go home and this to a step-down clinic, majority of them, and it is very rare that the treatment lasts for more than 1 month and then they are sent to the PICU or the PICU. Majority of them, by and large, they are treated and managed in this age group and they head home with their mother.
That's a wonderful job that everyone is doing here.
Pleasure. So from here we go to the pediatric ward, where you will get an opportunity to see and meet the patients who are admitted there.
Right,
and
but not all of them would be surgical patients.
No, they will both be the medical and the surgical patients.
Right, let's head over there then.
Let's go.
Okay, right now we're in the pediatric ward and we are going to talk to Dr. Nadeem about a surgery that actually occurred today, this morning, did you say?
This 3-year-old child had a very complicated surgery. She had a cyst in the neck. We call it the branchial cyst. So we did a surgery in the morning. As you can see, just few hours down the road, she's sitting well.
Up. Yeah, looks great. That's
and probably
wonderful.
would be heading home tomorrow just for keeping observation for a few hours. And by evening or tomorrow should be heading home.
Right, right. And tell me about how the parents found out it was a lump, did you say, that they noticed and then they came to see you?
Yeah, there was a small opening in the neck and there was discharging fluid, and for this treatment they came to us in our outpatient clinic here.
Okay.
And on examination we diagnosed it, we carried out certain tests, and following that they were offered surgery which they accepted, and this should cure the child.
And this surgery, is it an expensive one? What about the funds and the finances? Tell us about that for people who can't afford.
Absolutely. It's a very, very important question, because the limiting factor in our country are the funds. The private hospitals, they charge phenomenally high for surgeries like this, and the parents by and large cannot afford. And the public sector hospitals, they have a very long waiting list which can spread to years, and after pandemic the things have gone even worse.
True.
So here in this hospital, at Dr. Akbar Niazi Hospital, Sehat program, which is a flagship program of this government, they offer free treatment to these children, and if they are enrolled under this program, they are given a total free treatment.
That's fantastic.
This is
That's
fantastic.
wonderful.
Great help for these
That's
children.
wonderful, yeah.
So the place where we are standing right now is a pediatric ward, and at the back you can see there's a playroom.
Beautiful,
Where the children, they go and they play. And from here we can go to the operation theatres and have a little visit over there.
Let's do that.
These are the modular operation theatres. When we say modular operation theatre, it means that there are certain prerequisites and certain criteria. They are fitted with top-of-the-line filters. We call them the HEPA filters, which fills in all kind of bacteria and the viruses, they are taken out from the air. Okay. So there is no cross transmission, there is no cross contamination. Right. So these are well equipped theaters. As you can see, the central monitoring, and the patients are brought in here. All the major surgical procedures are done with utmost comfort. Not only that, we have a top line sterilization facilities here, because the ancillary services are as important as the surgery itself. So the equipment, the anesthesia machines, the monitoring equipment which are available, the sterilizations. So all of these are according to the international standards which are set in.
So do you have a different set of protocol when it comes to anesthetizing young children?
Yeah, we have pediatric anesthetists. Okay. These are the anesthetists who have been extensively trained in pediatric anesthesiology. And the children are brought in here, preferably once they are with the parents, they are made to go to sleep with a little injection, so that they do not cry. And so even the minute details are taken into account, how they are shifted here, how they are transported, how they are put onto the tables, what kind of postures they adopt. Even these IV lines that are put in, these require special care and special techniques. So everything for pediatric is different, and we have all those facilities here at Dr. Akbar Niazi Hospital.
Right. And what about patients that are a bit more nervous, do you give them something to sedate them before? What happens there? Yes. I'm talking generally because...
Yeah, we have patients who are like near teenage, and these are the children who are obviously, they are aware that they are going to undergo this procedure. So obviously these things have to be taken into account, and they are given some sedation before surgery. Right. So they are relaxed and they are within. So generally these children, slightly the younger age, are brought in with the toys, so they are playing with them. And our staff is highly trained here, who handle these children in the shifting process. And the anesthetists are ready to receive them, and once shifted, they are immediately put to sleep. And by the time they are waking up for minor procedures, they are with the parents, so they do not remember.
So they really don't know what happened.
Exactly.
Yeah, that's fantastic. Thank you very much.
Thank you. So from here we take you to another area which is very interesting, which is our executive outpatient, where we receive these patients and we register them before they are brought here for surgery.
Wonderful. I think I like this place the best. No, for other people, not for me.
Right. Thank you.
Okay, so this is where it all starts. Basically, these are the executive clinics where the children come to be registered?
Yes, these are the places where the preliminary examination is carried out. First, they are received here, the counters are set, and it's all computerized data so that we can go back and see the records, Right. And sometimes we have to get back to the parents and call them again for follow-up visits. So all that is recorded here. And a basic medical examination, which would include the weight and the height, the blood pressure, the temperature, the pulse. So all these are recorded by trained nurses. Right. And with this information, the child and with the parents, they sit here and they wait for the consultant. And the waiting time is very less here. And because some of them, they come by appointment, and some of them they walk in even, and the consultants are available here on their clinic designated time, and they are examined. And all the necessary tests which are required for that particular disease are written here, and then they are shown the way to carry out those tests.
Whatever the specialist they need to see. Yeah. Right, and so this is the OPD. What about the patients that come in the emergency and not in the OPD hours?
Yes, we have a fully functional accident and emergency, and it's not just the emergency, but the accident part also. The parents, they bring in children who fall from a roof, for instance, or a road traffic accident, which is so very common because the children are unattended and they're walking on the roads and they can end up with serious injuries.
Right.
So we have a well-equipped 24-hour round-the-clock working emergency services are available in this hospital, and the trained doctors and senior registrars and the surgeons and pediatricians and the nursing care is available. And those children are then not brought to the OPD, but they're taken directly to the ward, the ones who need admissions. And if any surgical intervention is required, we have an emergency theaters, which are well equipped to cater for those treatment. And if any child that needs admission in PICU or Nicu, they are taken to the respective levels and they are admitted over there.
So basically everything is covered there.
Absolutely, absolutely.
Right. Thank you very much, Dr. Nadeem Akta. You have given us so much of your valuable time and explained things so well, taking us through so many different departments, that I'm sure many parents will really be happy to know that there is a system in place and there are special people that they can see, because I think for a parent the most important thing is the well-being of their child. So thank you so much.
Thank you very much for coming here and being with us. And only one message that I want to give across to your program: child is a very special entity, needs special care, and take a lot of care of your children.
Thank you so much.
Thank you, Abbas.
That indeed is a wonderful message. And with that message, we come to the end of today's show. Hope you have enjoyed it. We certainly have. Until next week, stay happy, stay healthy. Bye-bye.